So this lecture, we're going to talk about chest pain, acute coronary syndrome. A lot of this is going to be review for you. So again, just some statistics. Chest pain, really common, 7.6 million annual visits to emergency departments. Second most complaint. Acute coronary syndrome, remember, an umbrella term looking at suspicion or confirmation of an acute myocardial ischemia or infarction. So non-ST elevation MI, unstable angina, ST elevation MI are types of acute coronary syndrome. Stable angina, chest pain that's a discomfort produced with exertion or stress, relieved by rest or sublingual nitro, a very predictable pattern. Then you have unstable angina, patients that are coming in with chest pain lasting greater than 10 minutes, not relieved, new or different than previous, with lasting about 4 to 6 weeks. Non-ST elevation MI, chest pain plus elevated biocardio markers, and then a ST elevation MI, all fit under that umbrella of an acute coronary syndrome. MI, whether it be non-ST elevation or ST elevation, again, is defined as presence of an acute myocardial injury detected by biocardiac markers and the evidence of acute myocardial ischemia. Unstable angina or non-ST elevation MI differ primarily in whether the ischemia is severe enough to cause significant myocardial damage, looking at those elevated cardiac biomarkers. Then unstable angina is further characterized based upon its characteristics at the time of presentation. So is it new onset, at rest, or early post-MI? Presentation, chest pain, neck pain, left arm, shoulder pain, dyspnea, epigastric pain. Remember, dyspnea, especially in women, can be anginal equivalent. Varies depending on the size of the ischemia. On EKG, you could have ST segment elevation or depression, T-wave inversion. Cardiac biomarkers, really looking at troponin now more than CKMB. And then differential, when it comes to chest pain, differential is pretty wide, anything from aortic dissection to pulmonary embolus, esophageal rupture, pneumothorax, pericarditis, gastroesophageal reflux disease, musculoskeletal. In musculoskeletal and GI, you see a lot of patients coming in with chest pain, and ends up they rule out for a acute coronary event, and it is a gastroesophageal or musculoskeletal event. When we look at risk stratification, determine likelihood of acute coronary syndrome, we look at the assessment. Are there findings high indicated of acute coronary syndrome, intermediate, or low? So, for example, they come in and they have a chest pain that is every time they exert themselves, they have it. It's classic symptomology, family history. That's a very high indication that it's likely acute coronary syndrome. Lower findings are, did they have a spicy dinner? Did it happen at rest? Have they ever had this before? So again, looking at, history, physical exam, EKG is important. They have new ST elevation or ST depression? Do they have, non-specific changes that are new from previous EKG? Or if they've never had an EKG, is the EKG concerning for an event? And then also looking at those serum cardiac markers. So again, differential diagnosis for chest pain. Musculoskeletal, definitely is one. Can you reproduce the pain when on physical exam? That's a big one. GI, is it esophageal spasm? Very painful. Sometimes you can give some viscous lidocaine, which will take that away. Also, calcium channel blockers and nitrates will take that away. Is it pulmonary nature, PE? Don't just think that you have to be hypoxic when someone comes in with a PE, because I've seen many pulmonary embolus with patients who are oxygenating just fine. Are they having cardiac dissection? Is there an aneurysm? Herpes zoster, shingles. I mean, I've gotten called to admit someone for possible acute coronary syndrome, and when you're doing your physical exam, they have shingles, and the other person didn't pick it up. So definitely. And then panic attacks, psychiatric. You see a lot of that too. And then this is just a graph of, when people come in with chest pain, about 42% gastrointestinal or disease, 31% ischemic heart disease, 28% chest wall syndrome or musculoskeletal pleurisy. You could read those. Again, history, you want to obtain a detailed history when the patient having chest pain, onset, anything that provokes it, what's the quality, radiation, what's the site of the pain, is it substernal, is it back, does it radiate, and then timing, is it constant, episodic, is there any pattern to it? So those are all things that you need to put in your history of present illness that not only helps you manage the patient better, but from a billing perspective, you need to make sure that's in there for to bill appropriately. And then ask about prior diagnostic studies. So have they had a stress test, CT angiogram? Have they had a cardiac cath in the past? Sometimes patients will come in, they've had a cath a month ago that showed clean coronaries, but they're having chest pain. So you need to look at other etiologies. Looking at risk factors. Risk factors include if you're male, over 55, family history of coronary artery disease, do you have diabetes, hypertension, hypercholesterolemia, tobacco use? And, cardiac risk factors are pretty poor predictors of an acute risk in symptomatic emergency departments. So a lot of times what the patient's presenting with is outweighs their predicted value. So, someone's coming in, I have left-sided chest pain, they have no history, they don't smoke, they're a runner. You can't just discard it and say, oh, well, you don't have a lot of risk factors, you're too young to have an MI. Targeted physical exam, again, vital signs, heart sounds, respiratory symptom, abdomen, neurologic status. EKG, need to determine, are they having an MI, an ST elevation MI, because that's a immediate trip to the cardiac cath lab, versus are they having a non-ST elevation MI, or is the EKG normal? Cardiac biomarkers, looking at troponin, depending on where you work, troponin I or troponin T. Very sensitive, but remember, other things can elevate troponin, sepsis, heart failure, just bad renal disease. All of those things can elevate troponins. Troponin, again, rises 4 to 6 hours after injury, can remain elevated up to 2 weeks. Troponin may continue to be elevated in patient with dermatomyositis. CKMB, really not checking those much anymore. Chest x-ray, you want to make sure there's no aortic dissection. That's the most important thing. 90% of people with acute aortic dissection have some chest x-ray abnormalities. So you're looking for wide mediastinum or aortic knob that is displaced. Aspirin, so you're going to give everyone who you suspect having an acute coronary event 162 milligrams to 325 of aspirin. If they can't swallow it, you're going to give it rectally. It's important that, don't just assume the patient got aspirin if you're going down to admit them. You need to make sure that they got that dose. When we're looking at predicted risk of death from an MI within and the need for urgent revascularization, 14 days, there's a TIMI risk score. So that just looks at their age, their risk factors. Do they have known stenosis? Did they have aspirin use in 7 days? Severe angina, increased markers, and that looks at prediction of risk of death. And then this is the heart score. So this is important. Most emergency departments will utilize this. So looking at the history, is it suspicious, moderately suspicious, slightly suspicious? What's the EKG look like? What's their age look like? What's the risk factors and the troponin? And based on the score, you could decide if you're going to admit the patient for observation, discharge the patient, or does the patient need, emergent cardiology evaluation for possible need to go to the cath lab. Usually it's utilized for patients that are not in that severity of chest pain. Care pathways, again, that's like the heart pathway is that scoring system. A lot of ERs use that to stratify the patient so they decide what we're going to do with the patient. Can the patient go home with an outpatient stress test? Does the patient need to come in for further evaluation, ruled out via enzymes, cardiology evaluation for CT, cardiac CT versus cath versus stress test? And then looking at low versus intermediate risk, this basically chest pain is you're risk stratifying the patient. And the risk stratification is, are they going to die? Are they with the risk of death versus not death? And then you're looking at what are the risk factors for coronary artery disease? Do they need to stay, go home? So when we look at all those, what's a low risk, intermediate risk, or high risk? High risk, those are those patients that have had hemodynamic instability, they have runs of VTAC, they have recurrent ischemia, they've had prior cardiac bypass surgery or prior interventions. Those are all high-risk patients. And then this is a slide talking about admit versus discharge. This is important because if you work in an emergency department, hospitalist group, you're going down to admit a patient, you need to be able to understand, okay, what's the risk of bringing them in versus having them discharged. And if a lot of places are now developing protocols where their heart soars a certain level, they may get an echo the next day and then a stress as an outpatient, or they may get a stress in the morning or additional cardiac imaging depending on the facility. Invasive versus conservative therapy. If a patient's having an ST elevation MI, that's an emergency that needs to go to the cath lab. Patients that have had known coronary artery disease are coming in with elevated troponin and non-ST elevation MI. We need to treat them to make sure that we're stopping the ischemia. We need to anticoagulate those patients and then plan for a coronary angiogram, followed by intervention or bypass. And then low risk, you're looking at, can we do CT angiogram? Do they need a stress test, or do we just watch and wait? Long-term management, these are secondary things, preventative things we can do as we learn, weight loss, smoking cessation, exercise, BP control, lipid management. And then long-term drug management, beta blockers, important. Always educate the patient that they can't stop the beta blocker. High-dose statin therapy. We'll have a lecture on more than you ever wanted to know about statin therapy. ACE plus or minus ACE inhibitors, and then aspirin definitely, and then Plavix or another antiplatelet medicine for 1 year if they've got a stent versus if we've just ruled them out and they have high cardiac risk factors, then they're going to need to be on just an aspirin. Then we talk about prismental variant angina. Usually occurs at rest, not usually with exertion. Associated with ST segment elevation, generally younger patients, few risk factors. Coronary cath usually shows transient coronary spasms. So these are treated with nitrates. I've seen it treated a lot with calcium channel blockers and aspirin. These are a lot of times female patients develop this and they have some coronary artery spasm. Cardiac cath goals, decrease the amount of myocardial necrosis, preserve LV function. And these are common sense things, prevent major other adverse events, treat life-threatening complications. We talk about medical therapy, patients coming with chest pain, whether it's a non-ST elevation or MI, you want to give them nitroglycerin, vasodilates, will help improve blood flow to the coronary arteries. Watch for hypotension, make sure if they're on Viagra or Cialis, you know that, so you can anticipate if they're going to have hypotension with it. Aspirin, as we talked about before, class 1 level A, so it's been proven in the literature we need to give the aspirin. will help reduce mortality in patients with an ST elevation MI. Obviously, if the patient has issues with GI bleed in the past, we need to be careful with that, but giving, sometimes the risk benefit, the risk and benefit, the aspirin risk is more beneficial, and you'll get more benefit out of it. Beta blockers, 14% reduction in mortality at 7 days, 23% long-term mortality reduction in patients that have had an ST elevation MI. So beta blockers are definitely important. Some contraindications: hypotension, bradycardia. ACE inhibitors, you're going to start patients with anterior wall or patients that have a low ejection fraction on ACE inhibitors. Those have been shown to decrease mortality. Start in the first 24 hours. And then if you're having someone that are bringing with a non-ST elevation MI, acute coronary syndrome, unstable angina, utilization of unfractionated heparin. So the benefit of putting the patients on a heparin drip versus low molecular weight heparin is that we stop that relatively close to when the patient's going to have a coronary artery cath done. Also, renal patients tolerate heparin drips better than Lovenox. You can adjust it for renal, but I tend to, if the patient has any type of renal insufficiency, go with just the heparin infusion and not the low molecular weight heparin. And then, additional medical therapies we can use, Plavix, give a Plavix load. Again, a lot of this directed by cardiology. You want to burst inhibition of platelet aggregation, so you want to stop those platelets from aggregating. And then looking at Integralin or ReaPro. A lot of times when we're doing coronary artery intervention, these are utilized during that period of time. And then looking at PPIs and dual antiplatelet therapy. So there's been some reports of adverse outcomes when aspirin and Plavix are accompanied by PPI. So some PPIs inhibit that P4150 metabolism. So omeprazole is one of them. So you want to make sure you're not utilizing that with aspirin and Plavix. There's been no convincing clinical trial that has showed that drug-to-drug interaction. So consider using a H2 antagonist as an alternative to PPI when the patient has dual antiplatelet therapy. NSAIDs and STEMI. So patients routinely take an NSAIDs. Those should be discontinued if they've had a ST elevation MI. I'm sure you've learned in pathophysiology or pharmacology about the NSAIDs and the cardiovascular risk. So increased risk of mortality and reinfarction if the patients are on NSAIDs. So they should not be administered during the hospitalization. I'm not a big fan of NSAIDs in the hospital setting at all. I usually don't use them for any patients. I usually manage Tylenol. Now, young, healthy people, different story, but try to avoid NSAIDs due to the increased cardiovascular risk and renal issues. Post-MI outpatient therapy, so follow-up, again, 2 to 6 months, stress testing 3 to 4 weeks after an MI, repeat EKG. These are all things cardiology hopefully is going to help you manage, continue them on their cardiac medications. And so that's just an overview of chest pain. We're going to go a little bit deeper with the next lecture, talking a little bit more about acute coronary syndrome and management of patients with MIs.